Hello, everyone, and a warm welcome to today's edition of Podcast. Today is October 18th, 2022. It's a Tuesday, and we are happy to welcome back Dr. Fausto Rodriguez, who is Professor and Chief of Neuropathology at David Geffen School of Medicine at the University of California, Los Angeles. And he is going to continue his update on the recent 2021 WHO classification of CNS tumors. And this would be the fifth and last update in the series. And today's topic is mesenchymal non-meningothelial tumors involving the central nervous system. And as always, you can feel free to post your questions and comments in the YouTube and Facebook chat windows, and we will be happy to pass them over to Dr. Rodriguez at the end of the session. Over to you now, Dr. Rodriguez, and thank you for joining us.
My pleasure. In fact, this is always a pleasure to be with you all and trying to share some of the experience that we do by just in our daily practice. And so as Irfan mentioned, this is the fifth and last of these. I selected several topics that were where I thought there were some updates that will be worth sharing, so we are aware of them. But in the future, we will try to select, as things develop, we will be selecting different topics that are of interest. I believe we're talking also about doing a frozen section series or a frozen section, CNS frozen section topic. And then I'll be probably also sharing several sessions with in the future of interesting cases. But today, let's go over mesenchymal, because as we know now, this is something that has changed a little bit. We now know, since we are applying a lot of genetic profiling to CNS tumors in many different contexts, something that has happened is that we're starting to encounter distinct entities that in the past we will classify them based on morphology and phenotype, but now we know that they can occur in the CNS. So this is the topic of today. So this is the classification of 2021 of the non-meningothelial tumor. Something that mesenchymal, something that we should have in mind is that essentially any type of soft tissue tumor can occur in the CNS. And usually when it happens, it occurs in soft tissue sites, which is dura or extraaxial. Now, in the past, we used to have this conventional wisdom was that if you have a tumor that occurs in the dura, you have to start thinking about, even if it's poorly differentiated, about sarcomas. You have to consider them. They occur usually external to the tumor, while you have tumors that occur in the CNS proper or in the parenchyma tend to be more primary CNS, neuropathological, etc. type of tumor, embryonal. But that is no longer the case. Again, with the increased availability of genetic tools, we are starting to see soft tissue sarcomas that actually occur in the substance of the CNS. So this is mesenchymal non-meningothelial tumors involving the CNS, not only the dura. Many times the dura is overrepresented. Sometimes you see them inside the ventricles, but they can occur also in the CNS parenchyma, something to be aware of. So you have to have a high index of suspicion when you see something even poorly differentiated in the CNS that doesn't fit very well in the glioma, embryonal, and other categories. So we're going to be talking about some of these particular tumors. Again, this is some tumors that are overrepresented that you may see in the CNS, but again, you can always encounter soft tissue tumors, and sometimes it's good to go to the evolving also soft tissue literature and soft tissue CNS, which is more comprehensive in the type of tumors that you will encounter. Let's start with one case. This is a 64-year-old woman presented with CNS symptoms. And this is the MRI. This is a flare, and this is a T2, and you can see a well-circumscribed lesion, maybe maybe a little bit superficially, maybe somewhat attached to dura with some edema around it. And this is the H&E. We have a spindle cell neoplasm. Every time we see a spindle cell neoplasm, you have to start thinking. The first thing that comes to mind, actually, if you're in the substance of the brain, you want to make sure there's not a gliosarcoma. That will be probably something that we see on occasion. And it can be the dominant component. So you want to look very carefully to make sure you don't have a primary CNS neoplasm, and it can be a focal finding. So that's something that is good to look at. And in this case, it's all the slides and try to look for some clues, whether this is a biphasic tumor or a primary spindle cell neoplasm. In this case, we have a primary spindle cell neoplasm that has a mesenchymal appearance. Something that was a little bit unusual about this, you had long fascicles in some areas, which is a little bit odd, but still something on occasion you can encounter. Funny looking vessels. And it does look very cellular and worrisome. So this is right from the bat, we feel that probably we're not dealing with a benign neoplasm, and that is worrisome. Looking around, showing you some of the components. And then, of course, we do a panel of immunostains for these. There were areas of increased proliferation, and try to see some. The other neoplasm that you have to think about, that you have to exclude, of course, is meningioma, because meningiomas are by far more common than mesenchymal tumors as primary CNS neoplasm. So you have to think, and there's a lot of wide variation in morphology with meningiomas. So something to have in mind when you have a spindle cell neoplasm in the dura, or even in impinging in the brain, whether you can be dealing with a meningioma. But there were areas like here you start seeing a bit more, some probably rare mites. And so it's a concerning cellular neoplasm, spindle cell neoplasm with mitotic activity. We did a panel of immunostains, and we did encounter some CD34 positivity. It was not the dominant one, but there was some CD34 positivity. We excluded, again, everything from glial to meningioma. And one important stain that came out positive was STAT6 in a nuclear fashion. It's not that this is not the most classic morphology, but you do have a spindle cell neoplasm that fits well, particularly with STAT6. And I believe this may have been also confirmed molecularly for solitary fibrous tumor. And this is a CNS WHO grade 2 based on increased mitotic activity. I didn't show you all the regions, but there certainly were areas of increased mitotic activity that satisfy criteria for it. So grading, again, something that you notice right off the bat for the 2021 classification is that there is no more hemangioblastoma. We have used that term for a long time, and it basically gradually disappeared, trying to reflect the wisdom from the soft tissue literature in a way, in a sense that many of these tumors that we call in the past hemangioblastoma, many of them represented just very cellular or malignant versions of solitary fibrous tumor, high-grade versions, and that they share a lot of the molecular. And then you have other tumors that actually may had some features of hemangioblastoma, but there were other entities. So that term lost traction, so soft tissue literature, and then now it has also lost traction completely in the CNS, where that term doesn't exist anymore. In the previous classification, you may have remembered that they were used, it was a hybrid term like solitary fibrous tumor / hemangioblastoma, but that has disappeared. We only have solitary fibrous tumor now. And what we have is, this is the grading. The grading there have been several papers come out with some good outcome data that have allowed us to clarify a little bit the grading of it in the CNS. And it's a 3-tier system. And you see grade 1, 2, and 3. The grade 1 is the ones that you see that they have the classic solitary fibrous tumor morphology. They have collagen, rope collagen, very little proliferation, less than 5 mitosis per 10 high power fields. And this is what we consider classic SFT, and they have a very good outcome. Now, grade 2 is something that starts seeing usually more cellular. They may have a mixture of solitary fibrous tumor classic, or what we sometimes have designated as HPC or hemangioblastoma, but greater than 5 mitosis per 10 high power fields. But more importantly, no necrosis. The presence of necrosis is a bad prognostic factor. And in the presence of brisk mitotic activity greater than 5 mitosis and necrosis, that will qualify for a grade 3. And most of these have an HPC morphology, but it's not required. What really is important here is the increased mitotic activity and the presence of necrosis. Next, we're moving into the next case, 78-year-old woman with a posterior fossa mass. And then we have here another spindle cell neoplasm. This was, by comparison, looks blander. You do have a spindle cell neoplasm, a bit of a mixoid background, maybe some pleomorphic cells, some cellular pleomorphism in areas, hyalonized vessels, not much for mitotic activity. And let's see some of these hyalonized vessels here. And we were seeing these maybe some to some extent some adipocytic metaplasia. A curious finding. Hyalonized vessels. And of course, here we have a differential diagnosis. Different entities come to mind. But more reassuringly, we are not seeing much for mitotic activity or hypercellularity. So we characterized it, did a panel of stains. This was also CD34 positive. And we also had nuclear STAT6 staining. So this is not a perfect one, but STAT6 can be variable. You really want to make sure that your clone is working well and you get used to it. And sometimes you may have false positives or false negatives. So you need to feel comfortable with your validation to make sure that it stains well. And you can see here, this one, we felt comfortable for it. The rest of the phenotype worked well. And this one actually was a little bit a solitary fibrous tumor with with an odd morphology. It was grade 1, again, less than 5 mitosis per 10 high power fields, but it was one of these what we call a mixoid type. So sometimes when you have a mixoid neoplasm, the CNS, you have to start thinking about a mixoid variant of solitary fibrous tumor. And this also has a little bit of adipocytic metaplasia, which is also something that has been reported and acknowledged in the soft tissue examples. Moving to the next case, it's a 45-year-old woman with a mass in the frontal lobe. We know we are in CNS. And something also to look at the CNS is important, as I mentioned, when you have something that looks to you that may be mesenchymal, it's good to have, if you have some brain next to it, it's good to look at it very carefully, because you can have a glial component, and that will make it more of a gliosarcoma or a biphasic neoplasm. So here you have a little bit of increase in cellularity, but it's good also to get used to what a reactive brain looks like next door. Let me just clean this up a little bit. This is all reactive brain. And you see it can be a little bit, it can be cellular. This one has some increased inflammation, a lot of plasma cells. Inflammation here. And now we're getting into the substance of the tumor. Some vascularity. And here it starts appearing. You have a lot of inflammation. And here you have actually more an overt mesenchymal appearance. The main thing here in this case is it was a superficial mass, was to exclude a meningioma variant of some kind. And you have something called a Mixoid variant of meningioma, which is properly a variation of the metaplastic subtype. So something to have in mind, and we have to explore that possibility with stains and other things, because again, most of the time, what you have is a variant. A meningioma has a lot of variation, and you want to make sure that you exclude meningioma every time that you have a CNS neoplasm that looks odd, mesenchymal, or otherwise. So this tumor has a mesenchymal component. It's kind of myxoid, funny looking vessels here, some chronicity, and a lot of chronic inflammation with plasma cells. So this one, again, we did an exhaustive. You can see here a lot of inflammation, which is spilling into the underlying brain, but it looks like the brain itself is mostly reactive. And a lot of stains were not very telling. Something that I find extremely helpful in this context is, let's see, this one is Desmin. This one had a kind of weak Desmin positivity. Most of the time in these cases, we have a lot of Desmin. Here it was a bit more limited. This was a little limited. There was some focal staining, because usually you don't have much in the way of myogenic differentiation or Desmin positivity in meningiomas and primary CNS tumors. There are exceptions. Sometimes astrocytes can stain and all that. But here, molecular was very helpful, and there was testing for EWSR with a break-apart probe, and we can see there's some signals, few signals, and separation, and this was compatible with a EWSR1 rearrangement, and this was diagnosed as intracranial mesenchymal tumor FET-CREP fusion positive. So a little bit of a fancy term, but the idea is that there are several families of FRET, which includes EWSR1. Sometimes you have ATF rearrangements as well, instead of in other family members of CREP. So this is an increasingly recognized category. This was recognized with a handful of tumors that were found that have this myxoid stroma and that have the alterations, the fusions that we associate with angiomatoid fibrous histiocytoma. And the question always arose whether these were some variants of AFH or angiomatoid fibrous histiocytoma, or if there were a distinct primary CNS mesenchymal tumor. And there were some subsequent reports that tested these hypotheses in detail, including this one, in which there was a comprehensive molecular study of this group of tumors with epigenetics. And what they found is that there were two epigenetic groups of these tumors, A group A and B, varied a little bit with an outcome. I believe the group B does a little bit worse, slight changes in morphology. But more importantly, they were separate from meningiomas, and they were close but separate also from angiomatoid fibrous histiocytoma. So, and clear cell sarcoma of soft tissue, which is another tumor that can have similar fusion types. So here we can see that this is actually now considered to be a distinct entity and separate from other soft tissue tumors and meningiomas, and therefore has been added in the WHO. So again, FET, most commonly you have an EWS fusion involving as a partner EWS, but not always. So even if you have a negative molecular result, this actually you have to probably consider other type of alterations. Next is case number 4. One-year-old girl with a tumor in the spinal canal. And we have here a primitive appearing tumor, very different from the type of tumors that we were seeing. This looks more like a round blue cell tumor, very cellular, mitotically active. And of course, here the differential diagnosis, some necrosis. So definitely a high-grade looking tumor. It doesn't look like anything good. You can see here again the primitive morphology. When we looked at it, the first thought is, well, this is some sort of Ewing sarcoma, right? And Ewings can present in the spine. I mean, we do see it not only most commonly involving bone and secondarily spreading in, the same in the calvarium, but we can also see it as a primary intraspinal tumor. So that was one of the first considerations here. You have to exclude a variety of embryonal tumors that may present a little bit more as an extraaxial mass. That includes ATRT, other embryonal neoplasms, distinct categories that can seed actually from the CNS, usually from the intracranial compartment. So, and also extracranial primaries. You can have metastases that involve the spine. So this had a wide differential diagnosis, and there was a panel of stains done. At the end, this was, again, molecular here was very helpful, and this demonstrated a CIC rearrangement. So this end up being fitting in and this was actually subsequently, because I think at that time we interpreted it as just primitive, round blue cell tumor, and I think the AWSR rearrangement was negative, so we place it in a primitive category, favoring some sort of round blue cell tumor, some sarcoma. But at the end, after profiling, a CIC rearrangement was detected. And now this is again a distinct category in the soft tissue WHO and in the CNS WHO. So and a lot of times the partners these docs for, but it looks like the CIC is the relevant partner for classification. They resemble Ewing sarcoma. Ewing sarcoma is more common, so by far is the first tumor type that you have to entertain, and may involve the brain or spine as a primary or metastatic tumor. There's some cases also of metastases, so it can happen either way. CD99 may be patchy. The NKX 2.2 is typically negative in contrast to Ewing's, and these are aggressive tumors, so they have really progressive course with metastasis, and which is unfortunate, but it's one of those tumors that in the past have been added these Ewing sarcoma-like tumors, and that have a bit of a different outcome, and they're now considered a different category of neoplasms. All right, so the next case is a 8-year-old boy that developed a progressive headaches for 2 weeks and had this mass, large mass, completely inside the brain. So this is a well-circumscribed mass. Here you have T1 with contrast, showing a well-circumscribed mass with edema around it, but completely inside the brain. which was very relevant. When they did this resection, the clinical impression was that this was a glioma of some kind. And there are a variety of gliomas that can occur as circumscribed masses in the childhood years. And that they found that they really were favoring this to be a primary glioma. And this is the morphologic appearance. So when we started looking at this, we were going with that impression. Yes, it is. The impression is that it's something glial, has a lot of pink processes. Even the smears, which I don't have here to show you, look a bit glial. PXA was the first thing that came to mind, this pleomorphic xanthoastrocytoma, because you do have these pleomorphic cells, some spindle cell areas. But I tell you, we had a lot of material for these, and we did a bunch of stains, an innumerable amount of stains. And there was a trace, GFAP was a little weak, and I said, well, it could still be something glial. PXA sometimes can have weak GFAP positivity. And something that actually changed our thinking a little bit at that time was a lot of pericellular reticulin. And, say, well, you say PXAs can have reticulin, but there was a lot of it. And I said, at the end, I started saying, something clicked. So, this is really something mesenchymal, because it doesn't lack a lot of the other markers, and has a lot of pericellular reticulin. And we looked carefully, was a lot of material around, and we didn't find anything for a convincing glial component. We had some entrapped brain, but not really convincing component. And of course, in retrospect, we start looking at stuff, and we see here something very distinctive, and it's these very nice globules. This is something that is highly characteristic. Not 100%. You can have, you can see things like this. You can have eosinophilic granular bodies, right, in a variety of tumors, but these are more than that. These are really intracytoplasmic globules of varying sizes. And you can see here, you see how loose they are, the cells, even though they are spindly. Sarcoma is not the first thing that comes to mind when you have these primarily in the inside of the brain. So this was a tricky case when we encounter it. See if you have another slide here with more of the same. Here looks more overtly mesenchymal, actually. Denser, a bit of fascicular arrangement. Infiltrating brain. Sarcomas, even though they may look circumscribed at a morphological, architectural level, they can really infiltrate the brain. And it's something that you see here. And you can also have a lot of reactive changes in the adjacent brain, reactive astrocytes that you have to interpret with a lot of caution. So here we have, that was a lesion. Here again is highlighting some of the pleomorphism, some of these globules, intracytoplasmic globules. They tend to be large and small. And here molecular was very helpful. There was profiling, and the main alterations that were found were two pathogenic mutations in DICER1. This is the karyotype in some ways, the chromosome plot derived from NGS data, and we can see there's a lot of changes, a lot of chromosomal region losses and gains. So some extent, some genomic instability. So basically, this was then all this putting everything together was interpreted as being one of these primary intracranial sarcomas that are DICER1 mutant. And this has been highlighted again in several papers over the years, starting in 2018, as a sarcoma that is rhabdomyosarcoma-like, they tend to have, not uncommonly, some desmin immunoreactivity, which is interesting. It's similar to intracranial mesenchymal tumor, mixoid intracranial mesenchymal mixoid tumor. But they are characterized by these DICER1 mutations. And they represent now a distinct type of entity. And these globules were highlighted in this publication, and they can also occur in the setting of NF1. They can have NF1 mutations. They can have a variety of RAS mutations. So it's one of those tumors. There's some other alterations that they can have in addition to the DICER1. It's just something to have in mind. But these globules, when you see them in a spindle cell neoplasm, is something that you really have to think about. Moving on to case number 6. This was a 5-year-old male with an orbital mass. So here, this is what you have. Another primitive looking tumor. If you go on high power, you can see round cell neoplasm. And that is worrisome. Primitive round cells. But what is really distinctive, you start seeing these focally, these almost basophilic, almost chondroid type of matrix. And it can be subtle, it can be very focal. But here we start seeing, and you see a little bit more of that here. Almost this chondroid matrix that occur. Something also that you can see in these tumors that was typical, you have these staghorn or HPC-like type of vessels here, branching. Kind of chondroid, almost chondroid material focally. More here. So this morphology is actually very typical for this tumor type. And this is a mesenchymal chondrosarcoma. It's a tumor, of course, that occurs outside of the CNS, but it's a biphasic neoplasm. It has a primitive round blue cell tumor appearance with islands of well-differentiated hyaline cartilage. And it's characterized, it's also a distinct molecular entity. It has these HA1 and COA2 fusions. So they are distinct from other tumor types. Why we highlight it in the CNS? It is often dural base. It can involve the vertebral bones as well. And actually the meninges is a common extraskeletal site. So when it occurs in the extracellular compartment, the meninges is one, if not the most common site for these tumors. So they can present as a mass in as a extraaxial mass that mimics meningioma preoperatively. But it's something also to have in mind. They look very primitive, as I showed you, and have this cartilage, which is a telltale sign of it. So another type of tumor that involves that can involve the CNS as a classic site, despite its relative rarity as a tumor. Okay, I want to finish with a bonus case. This is an 11-year-old girl that presented with headaches and a mass in the right lateral ventricle. You have here a very well circumscribed mass in the right lateral ventricle, very vascular. Here you have some of these reconstruction images that sometimes you get from MRI. So it was a very vascular looking tumor. This was the resection. It was a very solid mass with a lot of vessels And this is the high power, and this immediately makes you think of something. Stromal cells, nice capillary type of pattern. Positive for inhibin A. So this was actually an hemangioblastoma, and they presented and wanted to highlight it for two reasons. One of them is that hemangioblastoma used to be included in the CNS as one of the tumors of unknown origin or unknown histogenesis. They have these stromal cells that are characteristic and variable. Sometimes you don't see it, particularly in cauterized examples or in frozen sections. They can be challenging to recognize. And they were considered to be of unknown origin. And now it's more placed, it has been placed, given its increased vascularity and overlap with other mesenchymal tumors in the mesenchymal group. So just it's one of those classification moves that have been made in the WHO. And also wanted to highlight, the most common location, of course, is cerebellum and spinal cord, but occasionally in very rare instances, they can occur outside of that location. And that is important to have in mind. This patient did not have von Hippel-Lindau to the extent that we know, had a single mass. So something also with von Hippel-Lindau, you have to start thinking also of rare presentations. But this one, just a very unusual presentation for a tumor that has morphologic and immunophenotypic criteria for hemangioblastoma. All right, and that's some of the cases that I have for you today. As we have done in the past, I'm going to have a few multiple choice questions to help us review the material. And of course, this is open to, we would like to hear your opinions and discuss it. So let's start with question number 1. A well-circumscribed mass identified attached to dura. Histologic sections demonstrate a Mixoid background and desmin expression. So which of the following findings may help to confirm the diagnosis?
Yeah, I'm looking at the answers, so I will be updating. There are some answers for B as in boy. Yeah, more of the viewers are of the opinion for B, and someone else is also replying as D, and more of them are for B as in boy.
Okay, so that's a correct answer. EWSR 1 rearrangements, you can see them. This is, in some ways, this should make you, this type of pattern should make you think of this Mixoid intracranial tumor that has these FET-CREB rearrangements, fusions. Again, FET is a family of genes and includes EWSR as one of the most common, but you can have also ATF fusions and other things that substitute for EWSR1. You do have I think I presented to you also a Mixoid variant of solitary fibrous tumor. And that certainly can happen, but usually this is not the telltale sign here is that they usually are not desmin positive. There are exceptions, of course, in many of these spindle cell neoplasms, but the presence of desmin in something that looks mixoidy, looks mesenchymal in the CNS almost always makes me think at least into these intracranial mesenchymal mixoid neoplasm. Next case, a diagnosis of grade 3 solitary fibrous tumor in the CNS requires which of the following?
Yeah, I think most of our viewers are going for D. Yeah, more of them are saying that D is the right answer.
B as in boy?
No, D as in David.
Oh, necrosis. Oh, I'm sorry. Yeah. Okay. And that is correct. Necrosis. So remember that the diagnosis of grade 3 requires 5 or more mitosis per 10 high power fields. In addition, you need necrosis. That's the actual correct answer. Is something that is now new in this grading system. Hemorrhage in the past used to be one of the criteria. I think was proposed a number of years ago, but we we don't use that anymore for grading. Necrosis is a bit more objective way of interpreting negative histologic features that are associated with prognosis. A 5-year-old presented with an intracranial mass. So histologic examination demonstrated a spindle cell neoplasm with rare cells containing intracytoplasmic globules. Testing for mutation in which of the following genes may assist in the diagnosis.
Yeah, we see answers popping up already, and I think our viewers are of the opinion of C as in car.
All right, and that's the right answer. That's our one. Again, with many of these tumors, now we're seeing there's an increased use of NGS, which is more of a panel. You get a panel of different genes, but as far as knowing that this is part of the diagnosis in many ways is inactivation of this tumor suppressor gene, which is DICER1, and that recognizes this tumor that has a few morphologic features that are characteristic, but that probably require DICER1-4 confirmation and to be able to call it that. It's always okay to suggest it. There have been cases in which we haven't sequenced, but it reminds you of that, and you can suggest it in a diagnosis. And that's something I want to highlight here. Sometimes we don't have the tools to make this. We don't have the material. The material may be depleted for whatever reason. Some of these tumors require a lot of immunostains to arrive to even to a preliminary impression. So having comments, I really endorse having long comments, just stating the facts, stating things that are going through your mind. You say maybe this one, if there's material, in more precision is required, go for sequencing. You don't have to do it automatically necessarily. And nowadays it's very difficult to do that with NGS because it really requires, at least in the United States, initiation by the clinical team, actually the physicians that are seeing the patient face to face to be able to order it and to be reimbursed for it. So sometimes many of these, in particular consults in cases originating in outside institutions to your own, may require an extended comment with a differential diagnosis, and that's okay. The final question, a 10-year-old girl presented with a spinal mass, histologic examination demonstrated a round blue cell tumor with hyperproliferation. First of all, of course, we need to exclude an hematolymphoid neoplasm, which were excluded in this example. And which of the following alterations must be considered?
I think for this question too, our viewers are opting for C, that is C as in car.
Okay. And that is correct, CSA rearrangement. I will also try to exclude EWS, right? I mean, historically, we have seen Ewing sarcoma present this way as well. So it's one to highlight, but in a sense of new entities and new category diseases that we are starting to encounter, CIC is another one that has to be entertained in this particular context. And that's all I have for the moment.
Thank you so much, Dr. Rodriguez. This was a very informative session, and I'm sure our viewers enjoyed it as always. And we had a lot of viewers from different parts of the world who joined in. I am looking online for questions that they might have for you. You can stop sharing the screen, Dr. Rodriguez, if you don't mind. Yeah. So one question is about Hemangioblastoma. So, Do you have any comments from your side about how to sign out hemangiopericytomas, which used to be hemangiopericytomas, and if they don't have a molecular tests in their lab? There is one question.
No, that's always a problem. So actually, it has disappeared. It's not part of the diagnosis anymore. I will use it now, using it as pathologist, and that we have dealing with these patterns for a long time, highlighting it in the comment as saying you have an hemangiopericytoma-like pattern. I think it's not inappropriate. You can use that, but as far as top diagnosis, that has completely disappeared. So the main their differential, the main entity you have to have in mind is solitary fibrous tumor. So the problem with HPC not only is, most of them will represent probably solitary fibrous tumors in the CNS, but you have other tumors that have that type of morphology. Mesenchymal chondrosarcoma can have it too. So synovial sarcoma, all these things that can occur in the CNS can have an HPC-like pattern. So it has become a very imprecise type of diagnosis. So it's not endorsed, it's not allowed essentially in the WHO. I understand that, you may not have all the tools to be able to make it. And even STAT6, which helps in the confirmation, sometimes fails. I mean, I see that we have had problems in validating it, that occasionally you get false positives and false negatives. So you have to have a very high index of suspicion when you have a result that doesn't fit very well. So yes, it's a diagnosis that I will not advise to have as a top line, but that you can usually use it in your comment and say it has this hemangiopericytoma-like appearance and state, that diagnosis is not allowed. Our main consideration is solitary fibrous tumor, but you have to also try to exclude these other entities, for example, depending on what the immunostains show, if you have them. If it's purely morphology, calling it, spindle cell neoplasm and saying it has an HPC-like pattern, you have to consider solitary fibrous tumor is another way to approach it in the comments. So that's things like that I have done before. In particular, sometimes you may not have the tools or you may not have enough material to do it. So having a comment or calling it spindle cell neoplasm or mesenchymal tumor, high grade or low grade, you can try to estimate that based on mitotic activity, necrosis, as we did, maybe even use the grading system that is all morphology based, and then state that this is what you favor, but certainly not placing, I will not advise to place that as a top line diagnosis at the moment.
Right. Thank you, Dr. Rodriguez. There is another question from a viewer. So what is your experience with meningeal sarcomas post-radiation?
Excellent question. So we do see them from time to time. Always have to have it in mind. You do have the sarcomas post-radiation. You can have it in the dura or extraaxially, but they can also occur in the substance of the brain. So those are two things that you have to have in mind. You can have gliosarcomas in the substance of the brain, and some of them can actually extend a little bit superficially and even involve the dura. So those are two things to have in mind. Mike, when I see something that looks like a sarcoma, even in the setting of post-radiation, I look very carefully at the interface with the brain to make sure that there is this is not starting as a glial tumor. So that is something that I pay a lot of attention. And but certainly intracranial sarcomas do happen post-radiation. I don't know the numbers, but more likely usually it's years after radiation. We're seeing a lot of patients now survive radiation for a variety of intracranial tumors, medulloblastoma. You have childhood survivors of medulloblastomas, and then you start seeing tumors that develop post-radiation. The main tumor types that you see post-radiation are sarcomas, high-grade gliomas, and meningiomas. All those three tumors, you can see it in the setting of post-radiation, and they are all they're part of the same differential diagnosis. So that is how we approach it as pathologists, really, that those three settings are likely. And extraaxially, then if they're really totally attached to dura and not involved in the brain, the main two will be post-radiation sarcoma and meningioma as well.
Right. This is the next question, that if solitary fibrous tumor have low mitotic count but shows necrosis, is it grade 1?
And that is the grading system. Yes. So you need to have For calling it greater than grade 1, you need to have more than 5 mitosis per turn high power fields. So yeah, the necrosis is in the context of brisk mitotic activity. You need both to call it grade 3.
Right. And the next question, what is your experience on CNS leiomyosarcomas?
You do see them from time to time. Again, my message here is that any type of soft tissue sarcoma can happen there. All these entities that you see in the soft tissue, WHO, at one point or another, you go in the literature, you will find a case report of it. So many of these, you can pretty much see anything as a primary and also as a metastasis, which can be occult. Sometimes if you have a rare soft tissue tumor example, you have to really try to exclude metastasis. So that is certainly something that you can that you have to really exclude. So with leiomyosarcoma in specific, I've seen primary classic leiomyosarcomas. There are two things to have in mind. You can have a leiomyosarcoma-like type of appearance in a meningioma. There are some anaplastic meningiomas that can have a leiomyosarcoma arising from it. So that certainly happens. And there's this group of tumors that are occurring in immunosuppression that are these EBV-related smooth muscle tumors. And we have seen several of those arising in immunosuppressed patients in the CNS. And they can be challenging. Sometimes they can have S100 and other conflicting stains, be positive for other conflicting stains, but that is one. So if you have something that you are concerned about, smooth muscle differentiation in the CNS, make sure it's not a part of another tumor, either meningioma, glioma, if it's involving the brain, or that is immunosuppression is not present. If you have EBV as a tool in your lab, I will recommend testing for it as well.
Right. There is another follow-up question. Yeah, this is like this. So we have a dural sarcoma with spindle cells and focal lipoblast-like areas, only positive for S100 desmin, TLE, only positive for S100. Desmin, TLE, STAT6, SOX10 are negative.
And it has,
Dural sarcoma.
Dural sarcoma, TLE
with focal lipoblasts-like areas.
Yeah, that is, again, it could be many different things. I mean, everything has been probably can occur in the, when you look at the dura, and you are already in the mesenchymal camp with things that are atypical like this looking, pretty much it can be everything. So I would recommend to really look at it from the soft tissue perspective. And I think that's what you're doing. TLE only, TLE is very non-specific. Without looking at it, it's difficult for me to tell, man. You want to feel free to share it. I'm happy to review it. I love seeing these cases. So, so if you want to share, I'm happy to see it. But just with that TLE, I wouldn't know, by itself. TLE is a non-specific marker, really. You want to use it, in the context of other things. You can have primary lipoblastic tumors in the CNS. They're super rare. So most of the time when you have something with lipoblast or something that reminds you about lipoblast, I try to think of something else that can have adipocytic differentiation. One example was that solitary fibrous tumor that I showed you. They can have adipocytic differentiation. They are much more common intracranially than other sarcoma types, right? Or mesenchymal tumor types. So you can have lipoblastic differentiations in meningiomas. One thing about meningiomas, that is the metaplastic variant. That is one of the features that it has. It has adipocytic differentiation. They can look very odd, and EMA can be very, very focal. It's something to really have in mind that, you have to make sure that your EMA, it doesn't stain as epithelial tumors. So meningiomas, the EMA can be very, very focal. You have new markers, SSTR2, etc., that can help a little bit more. But in that context, I will try to really exclude some sort of funny meningioma, even if you don't have a good EMA. And then certainly it can be a variety of tumor types.
Right. So our colleague is saying that what is the best way to share the images with you? Do you think what you want the case to be sent to you, or how
that would be best, because that way, I usually, for consults and all that, it's better for us to see the whole case, and be able to do our stains and, and other testing if we can. If it's outside of the US, and if there are limited resources, for the patient, sometimes we're happy to review and try to try to help in any way we can, doing limited evaluation and stuff like that. But it's better to see the material. Occasionally, scanning the size can help, but it's better to really be able to see it. We are able to provide more information when we have slides and a blog, and good clinical information.
So they can email you, is it?
Absolutely.
Right.
Yeah.
Right.
So I'm in the website, in UCLA. So feel free to reach out. I'm happy to look at help in any way I can.
All right. No, thank you, Dr. Rodriguez. We appreciate it. So I think with that, we have come to the end of the Q&A session, Dr. Rodriguez, and you would be happy to know that we had several hundred viewers from across different parts of the world. And thanks to our viewers who have joined from as far as Zimbabwe, Kenya, Algeria, Mongolia, Canada, Mexico, Greece, Bolivia, Egypt, India, and a few joined from the US as well. And thanks to all of you for your support. And feel free to follow our YouTube channel and also follow our Facebook page, that is Pathcast. And we can also find Dr. Rodriguez's previous lectures on our website, that is pathologycast.com. And we will keep you informed when Dr. Rodriguez will be back with us. And we all know that he is a great teacher, and he has really presented a lot of great lectures on neuropathology. And hope to see you all again. Our next lecture will be on liver pathology on November 15th. So that would be delivered by Dr. Catriona McKenzie, who is a pathologist from Australia. So hope to see you at that time. And thank you again, Dr. Rodriguez, for this excellent talk.
My pleasure.
Thank
Hope you
you.
enjoy it. Thank you.